I thank all the organizers for giving me this opportunity. So I'm going to go pretty fast, and I'm not going to take too much time. It's just a different perspective to the concept that I want to portray here. It's not that interventional cardiology needs to start a neurology service as such for the whole world, where the cardiology is really very reluctant. So there's a different perspective that I want to go on to. So moving on straight away, I've kept this title as Be Your Own Friend. So by the end of the talk, you'll understand what this means. Yes, alhamdulillah, we did manage to do 300 mechanical thrombectomies at RIC yesterday. And it's all about teamwork. We've got neurologists, we've got radiologists, we've got interventional cardiologists, our nurses, our storekeepers, and most of all our administration and our executive director who's sitting here, without the support of whom we can't go on to these ventures. So moving on with my talk. So this is father of an interventional cardiologist who presented to us with 8 hours history of coma. And he had a basilar occlusion, so he had to be brought from a far off place. So it took him, I think, 6 hours to reach us and 2 hours while in that city. So 8 hours history of coma, and we can see the basilar artery occluded here. And we all know that basilar artery, if not intervened, has a mortality of 95% and more. And all we had to do was just aspirate the clot from there, and now you've got a completely patent basilar artery, and the gentleman went back home, alhamdulillah, and he's doing fine. This is father-in-law of an interventional cardiologist, 80 years old, 2 hours history of right-sided dense hemiplegia and aphasia, blocked ICA terminus, so half of the brain is devoid of blood supply. So this is Sulambra being performed, where we used a stent retriever and an aspiration catheter and a balloon tip guide catheter. And we've done Sulambra, and that's the stent that came out with the clot material. It's a completely recanalized artery there, and 48 hours later, the patient walked back home. This is father of our own cath nurse who assists us during the stroke procedures. So her father had a stroke, 65 years old gentleman, 50 minutes history of left-sided hemiplegia. Here you can see that the internal carotid artery is very tortuous. You can see it takes a complete 360 loop and then goes up. So it was very difficult to take the aspiration catheter up, and when we finally managed to go up, the catheter length finished because this loop consumed most of its length, and before reaching the actual site of occlusion, the aspiration catheter length finished. So then we decided to go carotid in this case, and we went ahead and performed a direct carotid artery puncture. And from there, you can see that's a tip injection that we've taken just to confirm that we are at the right place in the internal carotid. And then we've taken a 6 French sheath in, and that's the recanalized artery there. So these were just a few relatives to show that our own community can be affected with it, and our own relatives can be affected with it. So we need to think over it. We have the opportunity to learn the intervention. We must learn it while we still have the chance. So now this is, then we also perform a lot of interventional procedures where stroke is a complication, and we need to deal with that complication. I firmly believe that whatever complication a cardiologist has in the cath lab, he should be able to deal with it himself. You don't need to rely on others and wait for others to come in. So this is a case, this year's Pakistan Life 2023. This was a TAVI live case. So you can see Evolute R being deployed there. So I'll just omit the steps there. So that valve is being deployed. And the valve deployment went well. The procedure finished in time, and everything was fine. And half an hour later, while they were trying to extubate the patient from the vent, they realized that the patient was unable to speak and move the right side of the body. He had an occluded MCA M2 territory. So we went in. That's a microcatheter that is there. And so video is probably slow to play, so I'll just skip that. In any case, we went in, we performed a Sulambra, and on the table, the moment we removed the clot, patient regained 5/5 power. So it is a miraculous treatment when everything goes well, and if the patient presents early. it's a very useful intervention. Now, this is a doctor's wife. Our everyday scenario, severe mitral stenosis and atrial fibrillation. 36-year-old lady, 1 hour history of aphasia and right-sided dense hemiplegia. So we can see that the ICR terminus is blocked here. So you can see the whole brain is devoid of any circulation. So massive stroke. All we had to do was just go in and aspirate. That's the amount of clot that came out. And it's completely recanalized. And this is just few hours after thrombectomy. She's sitting up, she's moving her limbs, she's fine. Another 31-year-old lady, prosthetic mitral valve. Again, one of our own scenarios. 9 weeks pregnant, 4 hours history of left-sided hemiplegia. She also had an ICR terminus occlusion, and that's the stent with the material that came out, and it's all recanalized. And this is again, I think, an hour or 2 hours later in the CCU that she's able to move her arm, her leg, and she was discharged home walking. Peripartum cardiomyopathy, again cardiac issue. 30-year-old lady, ejection fraction of 15%, 3 hours history of left-sided hemiplegia. So we can see the blocked MCA here, and that's a completely recanalized artery. And this is again 72 hours later on the third day, she's going back home walking. Primary PCI. So we are all doing primary PCIs, we are all doing angioplasties. So right coronary artery, thrombus leaden, and while we were doing the case, we suddenly realized that the patient had become unresponsive. So we immediately performed cerebral angiogram, and we found that the left MCA was completely occluded. Immediately went in, just performed simple aspiration of thrombus, and that sticky 3 flow achieved. Issue resolved. So this, as Brad Nader mentioned, this was yesterday our 300th mechanical thrombectomy done at Rawalpindi Institute of Cardiology. So I would end my talk by just trying to give one message, that you should be able to manage your own complications. If you don't have the resources to run the service on behalf of neurology, then at least learn the intervention to be able to manage your own complications. And other than the major cities like Karachi, Rawalpindi, Islamabad, Lahore, none of the other cities has this intervention available. So what about yourself? What about your colleagues? What about your families? Who is going to treat them? Are you going to transfer them to different cities? Only three places doing this intervention? That's not enough for the rest of Pakistan. So we still have the opportunity. We need to get out of our comfort zones. We need to undergo the learning curve, and we need to learn this intervention. It's not difficult for interventional cardiologists. Till the time interventional neurology is trained enough and able to start this intervention, we have to fill up this vacuum. Thank you very much.